Okay, ladies and gentlemen, you're about to receive the world's first international medical podcast, hosted by three paramedics from different countries. Live from the UK, Finland and Australia, this is Group Call.
Hi guys, and thank you for tuning in. If you think that in terms of C-spine immobilization, everything has been said, and basically there's nothing else to add, I hope to surprise you. We have a few new devices, we have a few new thoughts. Timo Silva, Harrison Steed, and Alex Hepner. This is Group Call. Hi gents, let's start the whole conversation with a simple question. Do you like C-collars or not, Mr. Silva?
No, I do not.
Why?
I think they're cumbersome. They are really uncomfortable for the patient. And as far as I know, there hasn't been enough proof to actually justify using them. I think we are using them out of habit.
Harrison?
I pretty much completely agree with Timu there. They are very uncomfortable for the patient, and also I think for the provider as well, having to manipulate the patient sometimes in quite significant fashion to actually put them on. And like Timo, I don't believe there's any real evidence to show that they have been that effective in what they're designed to do. So
It's basically pretty much where I stand. I think that's actually the idea of C-spine immobilization is right. However, the devices we use is not great. But before we will get to the devices, Timo, what procedure are you guys using?
So basically, what we are meant to be doing is collaring pretty much everybody. If it's like an RTC rather, we should be collaring everybody, even people who are already walking around on the road when we get there, which is a bit funny. What really happens is most of the time we collar people who are still immobilized, like not moving and in their vehicle before we extricate, and then keep the collar on until we get to the hospital. If we don't collar, like a green patient that's walking around, then usually when we get to the hospital, the triage nurse will tell us off, find a collar and pop it on. And then the patient will have the collar until they have been scanned or whatever, and then the doctor will take it off, I think. So yeah, it is a bit weird. We tried implementing Nexus criteria, but it didn't sit well with the surgeons in the hospital.
Why so?
I think they are really set in their ways. I didn't actually hear the logic behind, like, why do we need to collar if the patient is Nexus negative? But still, they just wanted them. And apparently the discussion is coming up again pretty soon between the doctors, like our EMS docs and the surgeons in the hospital. And I just hope that our docs will be stirred enough to actually pull it through and get the collars out of our trucks.
Hold on. You said doctors. Do you have doctors on the ambulances or only paramedics?
We have one, like a doctor unit that I was actually working on yesterday with our EMS doc. So that's 12 hours every day, but only on days.
Yeah, I'm asking because you said that the discussion will be between doctors, and I thought, no, it should be amongst paramedics because we are in the field. We actually call up people, so that's why I was a bit surprised. Let's.
I was just about to say that I think it's only because like the docs like are supervising doctors make the rules, so to speak. So that's why they are having the discussion with the surgeons. And I'm happy. I don't want to go and argue with the surgeons.
No one wants to argue with people who have nice.
you don't get paid enough for that.
No, scarless. No. Just yeah, guys. If you want like that, yeah, we will keep it like that. Let's jump across to Australia, Mr. Steed.
Yeah, so we, at least in my service, we do use the Nexus criteria, or at least like a modified version of the Nexus criteria to screen our suspected spinal cord injury patients. Um, and it's been like that for, I believe, at least the last sort of 5 years in my service as a minimum. We are still collaring a lot of, say, elderly falls, particularly because with our modified Nexus criteria, anyone over the age of 65
That's correct.
doesn't
Yeah.
qualify for this modified criteria. However, it's still very sort of subjective from the paramedics as to who will be collared and who won't. I've seen a lot of people, and I traditionally have been sort of not sort of anti-collar, but other supportive measures. I've seen a lot of people not collar people that I even would, and yet I've seen a lot of people that have been perfectly fine, as you both have mentioned, and they still get a collar. So, but that screening has been effective, and there's been a greater push recently now for also like assisted extrication. So not saying, oh, we'll do everything for you onto the backboard and we'll manipulate you. Often it's done in a much more supportive way where the patients actually do it under their own power. So we might put them on a collar if they're in a motor vehicle collision, and then if they're able to help them to self-extricate, which is a lot more comfortable for the patient, we'll say.
Yeah, cool. From Polish perspective, we were as Timo, we were collaring almost every single patient, which was incredibly funny, but really bad. And then here in the UK, it's very trust specific. Basically, we follow either trust specific guidelines or a mixture of general calc advice and Nexus criteria or Canadian C-spine rules, which again is quite funny because well, okay, funny and not funny. Funny in the way that there are so many different ways, but not funny in the way that there is no consensus country-wise. To be honest, quick question, because basically with C-spine immobilization, as you know, guys, we supposed to later on in the transfer, we're supposed to achieve this tilt of 30 degrees with the head up to prevent raised ACP caused by collars. Do you do it in Finland, Mr. Silva?
We try to, but I don't want to go as far as to say that everybody does it every time. So it is advised to do that, but I doubt that it's done every time.
Quick question: how do you achieve it in transfer? So you have a patient on scoop on extrication board, and how do you technically achieve this tilt?
Just on the stretcher. So we don't use the hard backboards basically for our trauma patients ever. So it's only the what's like the suction mattress or the
vacuum
kind of deal.
Vacuum mattress, yeah.
Yeah, and then just trying to achieve it on the stretcher.
Harrison, do you do the thing 30 degrees if you collar?
Yeah, so I'll say that it's considered, but I wouldn't go as far as to say that people do it on a regular basis, to be honest with you. So our patients, our spinal patients are like Timu, like in Finland, are just lying on the stretcher itself, on the striker stretcher, so they're not on the spine board.
Are the stretchers available?
Yeah, exactly. So, which is good because I mean, like the stretchers themselves aren't comfortable to lie on. Lying on a hard nylon board for who knows how many minutes and hours would be much more uncomfortable. So at least there's some level of benefit there. But no, I wouldn't go as far as to say that we're routinely elevating that head of the bed. It does usually happen just for consideration of patient comfort, but I don't think it's very well described and disseminated down to the paramedics on the road that it's a good idea to regularly do that. You mentioned before about the raised ICP caused by the collars. We'll talk a little bit later about how we've sort of moved away from that as well.
Cool, thank you. Gents, let's jump from Australia to the United States, our amazing Gina sent us a video about how do they approach C-spine immobilization in the United States of America.
Hi, this is Gina LaRue-Wendy. I'm from the United States of America in St. Louis, Missouri. I'm currently in one of my classrooms. Today's topic is to C-collar or not to C-collar. So when I first started EMS a long time ago, they would make us C-collar and backboard every single person that had a trauma. You could have fallen up the stairs, you could have tripped on the same level, hitting your face, and you have complaints of neck or back pain. You would get a C-collar, backboard, trauma package, the whole 9 yards. So motor vehicle accidents, sports injuries, gymnastics, hockey, any type of involvement that could indicate mechanism injury enough for that C-spine. So with that being said, at that time, everybody was taught how to backboard and C-collar. So when I went, it was a national registry skill. So we have a national registry skill. That's how we get our national license. And then each state has their particular rules. So we'll have to get our state exam and or license. And then if you work in some of those states or live in some of those states that don't use the national registry, then you would have to get their region and or state license. So with that being said, it was a skill set that everybody was taught because a lot of agencies had still used the backboarding and C-collar. Well, about 5 to 10 years ago, and again, I'm not sure on the specific date of when they determined that backboarding is actually harmful or could potentially be harmful to the patient. So with that being said, if I fell going up the steps and I was having significant neck or back pain, and I have kyphosis, which is a humpback, and a lordosis, meaning a swayback, or I have spinal complications, maybe sclerosis or maybe chronic back pain, and you put somebody on this backboard that's a hard, flat piece of plastic, they're going to have a lot of anxiety, a lot of pain, maybe some shortness of breath. With that being said, then they're like, man, is this backboard and C-collar really doing any good? So then they're like, okay, hold on the backboard. Let's go ahead and still do modified spinal precautions. And they're like, oh, this makes sense. So with that being said, if there's a significant mechanism injury and or indications for neck or back pain or potential for injury, then we have that right to evaluate the patient, saying, hey, did you fall today? Does your neck or back hurt? And then physically assess these patients. A lot of times the adrenaline rushes because of our parasympathetic nervous system and our alpha and beta and our epinephrine release. Yeah, right? So we're all pumped up, but we don't even know if we're in pain or not. So they're like, well, physically do an assessment, check the neck for trachea deviation, JVD, and maybe step down, feel the back of the neck for any trauma. And if they still don't have any neck or back pain, then it's up to the paramedic to determine to C-collar or not to C-collar. So with me, if they have neck or back pain and they have an indication for this mechanism of injury, I'm going to go ahead and C-collar them. But if they fell up the stairs, they're not complaining of neck or back pain, and it's a low mechanism injury, then I'm not going to put a C-collar on them. But then again, follow your national and standard rules and protocols from each agency that you guys work for. So here in St. Louis, there's many different C-collars, just like it is in the United States, as well as the whole world probably has about 500 different types of C-collars. So maybe not that much, but you know what I'm saying, a lot. So with that being said, here in the United States, there's different types. When I first started, there was like 5. You had no neck, you had regular, you had tall, and you had to flip through the bag to figure it out, right? And then measure and apply them to the patients. So they determined, well, let's make it into one. It makes sense, right? Again, this has all of them. It's just the ones that I currently work with. Again, agencies in St. Louis could have many different others, but this is the one I'm currently familiar with. So this is the adult version. There's many different settings on the side, from your no neck to small to regular to tall. So this would like take the place of those 4 C-collars in your C-collar bag. You pop it out and then you adjust it to whatever that patient's neck is and their needs. And then we have a pediatric version. This is kind of cute. It's straight from the bag. What we do is we flip it over and then we apply the same concepts of pulling these out and adjusting it to the patient. Some agencies still carry some soft collars. Soft collars, it goes literally around, and these are indications for like very minor injuries as well. This is a great splint. So a lot of times we use it for other things other than a C collar. These are head blocks that we currently I'm familiar with, as well as the old school head blocks, the big orange things. So these head blocks, they're sticky on the back, and then this is where the head goes. This is the top of the headboard. You pull off these little tabs, and they actually stick to the backboard, and then you pull up, and then it becomes that head block. So that is what I'm familiar with here. I will tell you, though, that if I had a significant mechanism injury and they're not reliable, drugs, alcohol, go ahead and put a C-collar on. It's not going to hurt them. If they go to the hospital and they have a real complication, then at least you covered your butt. And then on top of that, it might be uncomfortable but a second, but it's going to be beneficial for that patient. So also too, self-splinting. If you arrive on scene and somebody is literally like self-splinting, I would go ahead and definitely C-collar them and follow your guidelines to backboarding. If you need to call in orders, you can, or it's up to you guys, whatever your protocols are saying for that, especially with a significant mechanism injury. It's something to consider. We don't do backboarding as much anymore. Again, that modified spinal precautions. So with that being said, here from the United States of America, this is Gina. So you apply it just like so. Have them stick out their tongue. And have a great night. Bye.
Thank you, Gina. Okay, guys, quick one, because again, Gina mentioned the mechanism of the injury and significant mechanism of the injury. And let me know your thoughts, because what I feel is that when we think about C-spine immobilization, we always think about big jobs and mechanism of the injury, and we always focus on this massive RTC or anything like that. But actually, majority of C-spine injuries are sustained in those minor traumas. Wouldn't you agree, Timo?
Yeah, definitely. I was just thinking when Harrison was talking about their modified Nexus rules that don't apply to anybody over 65, is that I actually was reading up on an article yesterday on SA Dream, and that was about trauma in the elderly. And I was thinking about our methods of collaring people in RCTs, but not the elderly that have fallen from standing and hit their head on something, obviously causing trauma to possibly to the neck as well, or the C-spine. And I was thinking, oh, that's not really good that we don't actually even consider these types of situations. We should, but I think most of us really don't. I think especially in the elderly, we tend to forget that a minor energy is a major to them, at least based on everything we know from studies.
Harrison?
Yeah. It's kind of interesting to say that too, because it's almost the reverse of what we've got over here, where we're almost less likely to collar someone that's been in a motor vehicle collision than we are an elderly person that's had a fall. That's
okay.
my experience in my service. So yeah. So, and I think a lot of it sort of comes down to when we look at the mechanism and we look at young, fit, healthy people, it does generally take a high degree of force to break a bone, a vertebrae, or whatever. Whereas with the elderly, and when they've got other comorbidities, osteoarthritis, kyphosis, all the weird spinal conditions that I can't pronounce very well, that force required drops and drops and drops. And I think it's also just an issue that I think we've overlooked a lot of it. I think Timo was alluding to that as well. Where because we go to them so often, you often go to elderly falls. It's a bit of that sort of that confirmation bias or association bias where I've been to 100 of these and they were all fine, therefore this person needs a collar. And that's where you come unglued as well, I think.
But it's also, I think that's apart from this bias you mentioned, there's also the compassion element to it, because let's face it, collars are not really nice to wear, to have them on your neck, so you think, actually it's elderly person, is in pain, so I will just drop the collar.
Yeah. I think that's definitely a part of it there.
So
and also I think in general, especially like when I was working in the UK, we were just always joking around that, okay, this job that we're going to do is basically a nan down, and it's kind of like, oh, this is really minor. We're just gonna go and pick the poor old lady up and make her some breakfast, and then she'll be continuing her day, and we'll be on our way. So it's just the mindset that we have with these kinds of jobs.
Yeah, absolutely.
And when you think of how stoic some of those older individuals can be, and how they can often hide and not disclose injuries they've sustained, it makes our job a lot more difficult as well in terms of the assessment.
True.
Exactly. So, guys, quick question: what alternative you offer to elderly patients who supposed to or should be immobilized and triple immobilized fully? So in the UK, what we do is we roll the blankets. So as Timo knows, because we worked together before, you roll the blue NHS blankets on the both sides of the head, and then you trauma tape the head, which is again thing that is quite interesting, because if you trauma tape the head or forehead to the board or to the scoop stretcher, you're supposed to actually trauma tape the forehead. But what we tend to do, unfortunately, again, this compassion element, is we tend to stick trauma tape together here on the forehead, not to actually trauma tape the eyebrows and later give them the free waxing service. But if it's the object, you don't actually immobilize. So that's this let's say alternative we offer to the elderly patients. However, it's not really supported by many NHS trusts. Timo, how it looks like in Finland?
Well, like I said, I think at least in my like where I work, we tend to ignore the elderly falls in terms of C-spine immobilization and immobilization in general. So we mostly immobilize if they have like major bone injuries, like a suspected pelvis fractures or like neck of femur and stuff like that. So we don't really even consider the neck. Yeah.
Then it's a hard collar.
Yeah. So then it's only a hard collar. And now we are talking about moving to a kind of like a blanket roll tape thingy, but it's a pre-made one that has like a styrofoam blanket, so to speak, like rolls, and then you already have the tape there, which is a bit wider than the brown trauma tape that we use in the UK. So that's probably coming.
Okay, did you?
But again, it depends on surgeons.
Of course, people with knives, scalpels. Did you have it actually? The thing you just described. Did you have it on you? Did you try it or not yet? Not yet.
Okay, no, not.
Harrison, any alternatives from Australia if you need to collar?
So if we're trying to avoid putting on a collar for compassionate reasons or another reason, but we still want to immobilize or at least reduce the range of motion of the spine. We'll often do the same thing and use blankets. So we'll roll them up, and they're probably sort of very similar in dimension to what you guys have. And it took me an embarrassingly long period of time to work out to roll it from underneath rather than over the top, because you roll it from over the top, it sits next to the patient and then it unrolls. But if you roll it from underneath, then the pressure of it holds the rolls nice and sturdy there. Occasionally as well, what we'll do is if you're really prepared at the start of your shift, you'll gather some towels and make towel rolls and actually secure them with tape so they're ready to go, almost like blocks, like padded blocks to put in. In terms of the securing the head to the stretcher, so in our protocols, we actually have a very clear message that says that the head is not to be independently secured to the stretcher. And a lot of it is sort of up for interpretation there. But when you think of, if you're securing just the head of the stretcher, just the head to the stretcher rather, and nothing for the rest of the body, then if that's staying there, it can potentially, pull the head off the shoulders, which isn't too good. But obviously we're using, your 5-point harness, seat belts and everything for the rest of it there. The way I personally fasten the head, for lack of a better term, is to tape it to the blanket roll itself, rather than over the actual head of the stretcher, because that way, if there is particularly some of the, we'll say, less skilled drivers going around the corner, it allows the body to sort of move as one unit, but the head's still got that stabilization there. Whereas if it's stuck to the head of the bed, the body can move, but the head kind of stays still. So that's just the way I personally go about it there.
Okay, cool. Thank you. Speaking of the devices, bear with. No, it's okay. Cool. Guys, speaking of the devices, what devices are you using in your services? Let me just show you this one. The one I use. So let's start with different types of devices. Here you go. That's what you can see across the services. You can see Philadelphia colors, you can see soft colors, Aspen colors, and Miami colors. In the UK, we use Aspen type colors, which are not really great. And to basically prove it, I will now pop it on my own. I measured this. Oh, I sized it earlier. And I will take it off when I will feel really uncomfortable. Timo, how it is in Finland?
Yeah, so we have the same one. And I'm actually going to join you in the discomfort, if I can actually pull it on myself. It's really hard to even put on yourself rather than the patient. But yeah, I just hate this. I actually can't even remember the last time I've used one, because I don't really collar people that are walking. I just take the blame from the nurses and the surgeons. There we go. It's not good, but it's there. And this is another thing. Like, obviously, I'm putting it on myself now, but if I'm putting it on a patient, oftentimes you see them put on really badly. So they're not even put on properly. So it's really hard. It's really hard to put them on, and it's really, really hard to put them on without causing more movement, lateral or posterior, anterior, posterior movements of the C-spine. So yeah. It's already bad.
I think the worst thing that collar is doing is hiding your beard as well.
Yeah.
Harrison, what do you have over there?
So in our service, about a year ago, we changed our protocols. So we had the Lurdle Aspen style that Timo is wearing at the moment. And in late 2020, we went through a review, because a lot of services in Australia and in New Zealand were actually moving away from rigid collars in favour of the soft collars, like the ones you pictured there. I don't have one to actually wear today, but if anyone's been on an airplane and had one of those soft pillows, it's effectively the same kind of thing. so they went through a lot of the literature that was available at the time, and I did actually manage to find some stats for you here in terms of how often we're collaring. So in our state, in Victoria, there's approximately 20,000 people per year that we put collars on. And as I said, at the time, it was rigid collars. And then it's found around 70 cases per year of patients actually having a traumatic spinal cord injury. So that incidence of actual spinal cord injuries versus people that are collaring is 0.35%. So it is quite low incidence there. So as I said, they reviewed it, and they've introduced these soft collars, which are much more comfortable for the patient. They don't have as many of the detriments that the rigid collars that you guys are both wearing do. So you don't get the raised ICP, you don't get the venous pooling, that feeling of nausea and vomiting as well, and just the discomfort, as well as the manipulation of the neck as well. When you look at, as Timu said, they're usually put on pretty poorly, and when they are put on properly and actually sized properly, they're often, you have to manipulate the patient quite a bit to actually get them on. So there was a study in another state here in Australia, in New South Wales, and it was about 2,000 patients that were in the study, and it was about 1,100 or so had a soft collar applied, and the remaining patients had a rigid collar applied. And of those, there was 2 patients in the rigid collar group that actually developed traumatic spinal cord injury from the application, and no patients in the soft collar group had any deleterious effects from the application as well. So they're a lot easier to apply. They're a lot more comfortable for the patient. And so far, in about 5 years or so, some of the states here have been using it. There haven't been any poor outcomes to be shown, which is really, really good. And there's also the fact, we don't know if I'd like to talk about it, but they're also cheaper as well. So the cost to the service is about half. So if we're collaring 20,000 patients a year, the old ones cost $10, these ones cost $5. It's about $100,000 a year that we're saving, which we can put into other things that actually work.
Cool. That's really interesting. Now, I thought about alternatives, because remember when I showed you the different types of collars, and I thought, do we have alternatives? And so I looked at the Miami collar, which is quite interesting, to be honest, from the construction point of view. But what I also found is X collar, and I actually contacted the person who developed the X collar. So here you go, straight from the United States. Actually, we received this video hour ago. Martin, here you go, mate.
Hi, my name is Martin Rizzo Patron, and I am the inventor of the X-Collar. Yes, I think conventional C-collars should be thrown to the bin, or even banned from use, especially in cases where you may have a patient with an unstable cervical spinal injury. The reason of this blunt claim is because we have done years and years of research, and all the clinical evidence that we have found lead us to pinpoint several drawbacks that these conventional devices bring to the table. Please, let me show you. In this picture, we can see a tomography reconstruction of a subject with an abnormal separation between vertebrae upon application of a conventional collar following manufacturer recommendations. If sustaining this abnormal separation, this obviously will occur at the weakest point, which will be the point of injury, and if sustained, this will create worsening, a distraction of the cervical spine, a distraction of the injury, and a worsening of outcomes. This problem is brought by design. Cervical collars, rigid plastic cervical collars, are designed as wedges to bridge the gap between the shoulders, the trapezius muscles, and the base of the cranium and the skull. thus creating an hyperextension effect upon any movement of the patient or changing positions of the patient. Another drawback that has been pinpointed by clinical evidence is the creation of a pressure points. In this picture, we can see the subject pressure point is created behind the earlobes, and in this location we have the venous return. So by blocking the venous return, these devices have the tendency to create an increase in intracranial pressure. So it's another important factor and drawback to consider when treating our patients. These drawbacks and clinical evidence has been thoroughly published, documented, so there is a lot of literature to support these claims. Another drawback that conventional C-collars bring to the table is the creation of a pivot point high on the cervical spine between the base of the cranium due to the application of the device and it working as a wedge. So we need to look at these points, how the fundamental way the device is working, wedging and not protecting the injury. Okay, another problem with cervical collars is that they have been designed with very little adjustments. We don't have control bilaterally. In a few models you do, in others you don't. Then you have a little bit of adjustments up and down vertically for the length of neck. So this led us to the development of the original X-Collar that we launched in 2008. This, as you can see, doesn't have any expansion or blockage bilaterally around the neck, but it has points to support the head, so it bridges above C1 behind the occipital and below C7 between the scapula to provide proper support posteriorly above and below the injury, and posterior and anterior, so facial features, cheekbones, mandible, and going down to the upper sternum. This is the original X-Collar launched in 2008. In 2018, we launched the new X-Collar, which was awarded an innovation award in the EMS World Conference. Here you can see big access port, again, going above C1, below C7, posterior and anterior to create a proper splinting system that can allow you for application on the patient and even in positions other than neutral. Especially in cases where you want to keep a patient on position of comfort. So we found a big problem with the way the conventional C-collars were working. This also brings up to the point of the way we use it, the protocols, the procedures that we're using. Okay, so in a way is a problem like the chicken and the egg. How can we update protocols and procedures and do better patient assessment to check for if there is any neurodeficits and to define, yes, we need to treat the patient or what to do, what's the next most important priority. So the creation of a splinting system for us was nothing but logic. It was going back to basis, changing the fundamentals on which how those conventional C-collars were attempting to do the job. Now, with better tools, now we see many updated protocols in many regions. So how do I see cervical spinal procedures in the future? What do I see is going to be the future of cervical collars? I think they're going to become obsolete. Cervical collars will be no longer used in the foreseeable future. Their usage is diminishing substantially. No longer agencies are providing for immobilization precautions upon just a mechanism of injury. They're looking deeper in the patient's conditions and providing better, proper care for patients. No longer keeping patients on backboards, because obviously they have also drawbacks, pressure points, extended use, the difficulty in breathing for the straps and such. The future for C-collars, I think, is clear. They're gonna go away. In many cases, sometimes it's better even not to use anything. The future, I think, will bring cervical splinting a stronger position for the treatment of patients with potential cervical spinal injuries. We already offer 2 different models of devices, and I think many others are going to come with similar or a little bit different options for cervical spinal splinting in the pre-hospital setting. We have a website, X-Collar, www.xcollar.com, that you can find a lot of the literature and the clinical evidence that I'm talking about. There is a lot more to speak about, just talking about cervical spinal precautions. Thank you so much for your time. You have a blessed day.
Thank you, Martin. You know what? I need to remove that. I'm sorry. I'm 7 minutes, 8 minutes, and I feel trapped. I feel really claustrophobic. It doesn't really feel good. Timu, are you?
Yeah. I must say, for everyone that was watching the video and couldn't see Timu and Alex, their cameras showing, you could see how uncomfortable it was that whole time.
Timu?
I was just waiting and trying to bear with the collar, because I wanted to do a short demonstration before I removed this, because actually I've now adjusted it a couple of times, which is obviously not what you're supposed to do. You're supposed to pop it on, do it right the first time, then leave it and remove it when you don't want to have it on your patient anymore. So I've adjusted it. It should be as good as it gets now. If I try to move anterior posterior movements from my neck, it doesn't actually probably move my C1, C2. But if I actually do lateral movements, I can wiggle around quite a bit, and I don't think it's actually supporting my lateral, or restricting my lateral movements in my C-spine. Oh shit, that hurts. Maybe if the patient has this on, they won't do this wiggling motion that I just demonstrated, but then again, they might, because they are really uncomfortable. They want to get some movement. They feel they should. They feel like they can, and then they will. And then again, it probably doesn't hurt the patient, but then again, the collar is not helping anymore. So yeah.
I think that's really the tagline, the takeaway from this discussion. You could obviously move quite a bit with the collar, so they're not really calling it spinal immobilization. I don't think is really the right term, because we're not immobilizing the spine.
Exactly.
We're helping to support. We're reminding the patient to not move, but then again, if it was hurting, they probably would be doing that themselves. So it's not doing what we're hoping it will do, but it's also doing all these bad things, and having detriment. So that's the sort of question of why are we doing it with the devices that we have at the moment? That the X-Collar that Martin showed in the video there is quite interesting. I like that it secures at firmer structures. It sort of stays away from the soft areas around the jugular there, and relies on much firmer structures for support. So I think that's quite interesting. It'll be interesting to see how that comes along. And then Alex is going to show us another quite interesting and novel one that I have not seen before.
Yes, indeed. So this is Do.You.Collar, which is currently used by Israel Defense Forces. So it has a few elements I need to show you. The first one is here. To those 2 elements supposed to go where the angle of the jaw is and maintain the airway, together with this chin element. And I will demonstrate you guys how it works. Let me put it on myself. So those elements, as I said, those orange bits which are movable are going to where the angle of the jaw is. And now I will try to pop it on myself, which is not really easy, especially with the headphones on. Let me remove my headphones now. This one. And then the chin strap goes here. And hooks up here. Now headphones back.
Compared to how's the comfort of that one compared to the one you just had on?
So in terms of comfort, I need to say that this is far better. It feels not only more stable, so those lateral movements Timo mentioned are definitely reduced. Anterior posterior slightly better, but still I mean, I can still move, but not as much as with the previous Aspen type collar. And well, it's the first minute I have it on myself, but I don't feel claustrophobic. I don't feel bad. It actually feels good. And what's important, guys, with this type of collar, it has been designed to actually allow to perform airway maneuvers, even intubation. And that's what I wanted to add, guys, because when we think about C-spine immobilization, especially after a significant mechanism of injury, we need to remember that there will be further procedures we will need to perform, i.e. intubation, i.e. I don't know, any airway maneuvers. So actually those two bits are almost performing a jaw thrust on me, which is again quite surprising, but definitely doesn't feel bad or very, very restrictive. So one more thing, because I mentioned intubation, and you know what, guys, with triple immobilized patient with in the collar, if you want to intubate, you have to remove the collar, because you want this significant hyperextension of the neck. So I would say, if we are changing approach to C-spine immobilization, if we are using different devices to immobilize the C-spine, let's think about different devices in terms of performing the airway maneuvers and securing the airway. So what I've got here is the VS scope, and I will showcase it later in one of the group call videos. But this device is absolutely amazing. To me, it's a game changer in terms of intubation, especially triple immobilized patients, because you don't have to achieve this significant hyperextension of the neck. All you have to do is just actually slide it. You can even perform paraglossial intubations from the lateral aspect of the mouth. You don't have to fight this bulk of the tongue here. So yeah, my takeaway point for today, guys, is let's keep the idea of C-spine immobilization, but let's change the devices we use. Would you agree, Harrison?
Yeah, absolutely. I think the devices, the traditional devices, have been shown to be detrimental and haven't shown to be beneficial. There's really no high-level evidence to show that they're doing what we intend them to do. And I think the bottom line for everyone's clinical practice should be do what's best for your patient. And not every circumstance is going to be exactly the same. There's going to be plenty of circumstances where a collar is warranted and is easy to put on and is effective. And there's going to be equally as many, and I would probably argue more, that it's going to be difficult to put on and detrimental. So really just assess what you've got, the equipment that you've got, the patient you've got, and the scene and the other resources, and decide what's best. Is it best to put a rigid collar on? Is it best to put a soft collar on if that's your protocol? Is it best to just do towel rolls and just, calm the patient down, analgesia if required, and say, look, I know it's uncomfortable, but just try lie still as much as you can for me. And often, in my experience, that's been more than enough.
Yeah, that's actually a good point, because we tend to forget about power of TLC, tenderness loving care, and just verbal immobilization, which is actually a good idea. Timu?
Yeah, I have to agree with Harrison, and you very much do what's best for your patient in terms of everything, but obviously immobilization as well. One more point that I wanted to bring up is a recent study in Scandinavian Journal of Trauma and Resuscitation and Emergency Medicine by Not Beam et al. They tested anterior, posterior, and lateral movements when extricating patients with a collar on, without a collar, with instructions, without instructions. Obviously, these were healthy patients. It was like a simulated situation. And they found that the best results and the least amount of movement in the C-spine was with no instructions and with the collar on. But then again, they also pointed out that it also takes time to do like loads of immobilization maneuvers, which we don't know that work or don't work. It's up in the air still. So immobilize for your patient, not for the system, and then also consider everything else that you need to do then, and things that are actually time critical, like airway, circulation, catastrophic hemorrhage, all that stuff that you might not be able to do on a trapped patient if you are wasting all this time immobilizing them before you extricate and all that stuff. And then for myself, for my colleagues in Finland, and obviously for everybody everywhere, remember the elderly, and not all patients are in massive pileups on the motorway.
Exactly.
And people can have C-spine injuries at home.
Exactly. Thank you. Guys, I hope you like this episode. Please let us know in comments below. What do you think? What is your approach to triple immobilization? Did you like the devices shown by us? By the way, all the additional references and website addresses will be in the description to this video. Timu, do you want to put it back?
I'm kind of missing it already. No, not really.
Just the warm embrace.
Yeah.
Guys, thank you so much. Timu Silva, Harrison Steed, Alex Hepner. This was Group Call.